Which way? Two more, three more to the right.
Yeah, top. Keep going to the
Keep
right.
going, keep going.
One more. One more. One more.
One more.
One more.
That one. And then there.
This one.
Okay, so we're going to talk about syncope today, better known in Alabama as spells. Skim come over my eyes. There's a common problem y'all see in the wards, even more common in the emergency room. One thing that we'd like to have the competition, like to make things fun. It's fun for us too. But I think one thing that does it encourages y'all to jump at a diagnosis, kind of be the hero, be the one that got it right, rather than go through a differential. I'm all about going through the differential and tell me how you got there. So just keep in mind, even though we're doing that in this exercise, in real life, if you just jump to the diagnosis, you're going to be the hero, the star. But when you make a mistake, it's going to be bad. It's going to be real bad. So anyway, just keep that in mind. There we go. So I'm going to just go through a model that I kind of use for when I have some of the syncope. And it really doesn't matter what, like everything in medicine, every differential, you've got a model. So the big heading first is vascular. So in vascular syncope, first orthostatic, because of autonomic insufficiency. And a bunch of things can cause autonomic insufficiency. So Dr. Madan, what are the things that we usually see, the most common things? I'm sorry.
Bonu's looking around.
Jordan, what are the common things?
You trying to say we all look alike? Is that what you're trying to say? Is that what I'm getting here, Kenneth? Okay.
Vascular vital syncope, autonomic insufficiency.
So what are the things, when you use autonomic insufficiency, what causes that? What common illnesses do we see cause that?
Any spinal problems like transverse myelitis or any spinal cord injury that might cause autonomic insufficiency, and chronic neurological conditions like Parkinson's disease.
Okay, Parkinson's with autonomic insufficiency, but what's the most common thing we see?
There's a week.
So vasovagal.
No. This is autonomic insufficiency. We're gonna get to vasovagal and neurocardiogenic in just a minute. Diabetes. I mean, so diabetes and getting old. I mean, that's kind of the things we see. And we see it all the time. Now, the other things that can do it that are much less common, but those are the common things. Obviously, volume is a big deal. So if you're trying to see if somebody's volume depleted has autonomic insufficiency, what on exam do you do? And tell me how you do the postural vital.
So we do it in three settings. So first we do the blood pressure and then heart rate while the patient is supine, and after that we'll ask the patient to sit up with his legs down the bed, and then we'll wait for 2 minutes and then check the blood pressure and heart rate again, and then we'll ask the patient to stand up and then wait for 2 minutes, and then check his blood pressure and heart rate again.
Okay. I'd say maybe 3 minutes. Some people, can have an immediate 50 millimeter drop and they recover, but when we're talking about autonomic insufficiency, you usually wait about 3 minutes. And one thing to remember about that is, if somebody doesn't have it when you first examine them, that doesn't rule it out. You need to repeat that throughout the day. All right, now, drugs is something I think speaks for itself. Almost everything we use, hypertension drugs, antidepressants, the alpha blockers can cause orthostatic problems. All right, now, on the reflex-mediated carotid hypersensitivity is something that it's not that uncommon, but you got to look for it. So, doctor, how do you look for carotid hypersensitivity?
Sometimes in history, the patient's shaving or wearing a tight collar and then they're passing out. sure on exam if I can re-stimulate the carotid and
Oh, sure you can. What do you want to do first?
make sure he's sitting there.
Well, you want to be sure he doesn't have a bruise, he doesn't have a history of a stroke or TIA.
Do you have any data on the sensitivity for that, like listening prior to?
I don't know, but I just know that the incidence of causing some neurologic death is about 1 in 1,000. If you ask them that and you listen, then it's pretty remote. So, all right, so you want to do it with them lying down, standing up,
Just
posed,
thinking
lying?
it would be safer for him to be sitting down.
Okay, so you want them sitting down or lying down? I mean, there must be a reason I'm asking you this. Is there any reason you want them to do it lying down and standing up, or just standing up?
I'm not sure.
Okay, remember, when you have someone that has a vagal spell, sometimes they have a drop in their blood pressure, sometimes they have a drop in their blood pressure and their heart rate. Rarely, they just have a drop in their heart rate. So if you're trying to see if someone has carotid hypersensitivity, I mean, I don't do it lying down and standing up. I get them to stand up or sit up and do it, and then you'll catch both of them. If they have, you know, the blood pressure drops or their rate drops, you're gonna catch it both ways. If they're lying down and their blood pressure drops, you might not necessarily, I mean, you're not necessarily taking their blood pressure. That's not something I check their blood pressure when I'm doing. I check their symptoms. You following me? So if they're standing up and they have either kind of abnormal response, you're gonna catch it. Okay. So then the neurocardiogenic syncope is probably the most common thing in young people, for sure. I mean, what is that? What's the mechanism of that?
Urocardiogenic would be sudden, like stimulation will suddenly drop out and suddenly come right back.
I mean, what's happening with the,
Vagal stimulation.
Sympathetic,
Right, so-
parasympathetic.
so what's thought is that people have, they have blood pool and the heart's hypercontractile, and they have abnormal, that from baroreceptors from their heart also, and they have a big, huge parasympathetic surge and get bradycardic or hypotensive. And when we say situational kind of neurocardiogenic, what are those things?
Emotional stress.
Like somebody's taking a leak, coughing, those would be
Strain.
the situational things. All right, and anatomic are pretty uncommon, but in my mind, that would be things like subclavian steel, which I don't know that I've seen it called syncope. Okay. Okay. Now, the cardiac, I think, are a little bit different animal, and I think the big thing is to have the differential, but to realize that it is a different animal because it's something you don't want to miss. Because if you miss it, it's a catastrophe. The other thing is that just because somebody has something you think is neurocardiogenic, like they have spells, you put them on a tilt table, their blood pressure drops to 50 and they pass out, that doesn't exclude something else. There was a case of a guy, the man that played for the Celtics, that passed out and he was evaluated and he had a positive tilt table and he passed out while he was playing, worked him up, calf normal, positive tilt table, played again, and the next time he didn't have syncope because he didn't wake up, he had sudden death. So just remember, if you have one thing, it doesn't exclude another. And then along the cardiac causes, the bradycardia, the pauses, WW, QT, Brugada. Most of the time, those are the people that have a pretty obvious heart disease, but in the case of iron channel problems, they may not.
So tilt table, do we have to do do we do it for diagnosis of neurocardiogenic, or it's more of a textbook thing?
Now, I'll make a confession, I've never in my life ordered a tilt table test. And So I think the diagnosis of neurocardiogenic syncope is basically historical. So, you know, I just don't, I'm just not sure that I
We
need
have
to.
never really seen it being done that much. It's just that we read about it.
Yeah, I mean, it's done. We do them rarely in Montgomery, but it's not very often. All right, and then one of the things that resemble syncope, neurologic problems, some metabolic problems. But again, the history is so different in these than somebody that has a sudden loss of consciousness and a pretty sudden recovery. And then psychogenic, and we've seen that on the wards recently in that plenty of times we had the guy with Charcot-Marie-Tooth and all kind of somatic problems acting out. And then catastrophic CNS problems like subarachnoid bleed, or don't ever forget blood loss. One thing that I think that y'all don't do enough rectal exams. So, I mean, really that should be part of everybody that comes in should have a rectal exam.
Don't pay you to say
So. But I mean, that just should be part of your exam. And then syncope of unknown etiology is probably 20% of the cases you look and don't find anything. All right, and then this is one way that I really think of it when I'm going to see somebody, I get a call or whatever, is that it's catastrophic versus non-catastrophic. In other words, the things that are going to cause death or catastrophic problems immediately are mainly rhythm and mechanical heart related versus the neural causes. So the neural causes probably don't, even though we admit those people, they don't need to be admitted. But obviously these people need something done immediately. So here's some, I guess, signs and symptoms. Let's just go around and what does that make you think of? What would be the diagnosis?
Vasovagal.
Right, neurocardiogenic, okay. Satoshi, following head movements.
It would be benign paroxysmal positional vertigo.
Okay, doesn't usually make you pass out, but that's a good thought. What else?
Seizure. Oh, okay, carotid.
What if they turn the head like that and have a tight collar and carotid? And then what if they say, Doc, every time I look up, I pass out? Like a 70-year-old person, what would that?
It would be hypersensitivity to
No, they look up and they pass out. What would that make you think of? It makes you think of vertebral base or insufficiency. You know, they crimp their vertebrals and the bony spinal cord, column and pass out. Okay. All right. What about highly emotionally charged situations? Vasovagal, neurocardiogenic. Okay. All right. What about? Okay. Those would be vasovagal, what we call situational. All right. What about prolonged standing?
I don't know.
So it's neurocardiogenic. I mean, that's okay. What about after a prolonged coughing fit? Jordan. And it's not, what happens when someone's coughing? They're what? Right, they decrease venous return. That can, someone that coughs all the time, that's somebody that I would, that falls and hurts themselves, bad lung disease, would need narcotics in that case. All right, that's a family history, sudden death, crib death, congenital deafness.
Holcomb?
Holcomb might be family history, but not crib death or deafness. So it'd be someone with congenital QT prolongation, like Romano Ward syndrome. I mean, it doesn't have to be, you know, it's autosomal dominant, but it can be just isolated mutation.
I had a patient with ONCAT, I think it was the same month that you were interned. We had this guy, whenever he would back up, he'd turn his head and his seatbelt would push and he'd pass out. It's like
I mean,
an
it's,
80-year-old guy.
I'm just telling you, it's embarrassing when somebody, or somebody to send you somebody and say, oh yeah, I did, especially with carotid, you passed out, and you didn't do it. I mean, okay. Well-trained athlete following exertion.
Excessive vagal stimulation.
Yeah, okay. Keep a well-trained athlete during exertion. Could be, but if you have somebody that passed out during exertion, that red flag better go up. So what, right, hokum would be a big one, and then ischemia. So I mean, if, you know, hokum's not very common in a young athlete, neither is ischemia, but there's either one time, if I thought it was had some chest pain, I might do a coronary CTA to see if they have anomalous coronaries. If we do TE and look at the coronary course, immediate course also. Okay. Vanessa, what about macrolides, quinolones, antidepressants, antifungals? Acute prolongation. And then what usually happens is somebody is on one and then they go to a different doctor and the doctor doesn't take a history and puts them on another. And I mean, that's what happens to people. And they die at home or they have a bunch of spells. All right, proceed about aura.
Seizure?
Yeah, mostly be a seizure. And what about when somebody has a vagal spell and they wake up versus a seizure and they wake up, what's the difference? Which means they have a what, prolonged what?
A seizure when they have post-ictal.
And they're so they're like out of it for a good while. And somebody has a vagal spell, they might be tired, but they're back with the program right away. Okay, no, not that smart. Okay, all right. Frequent syncope, no trauma. See it all the time.
Vasovagal. Cardiogenic?
No, what if somebody say they're what now? Right. I mean that's common. I mean, you know, I see people all the time. I say all the time, doc. And if they got all their teeth, they're not passing out. All right. What post-bed rest for 3 days?
Posture.
Could be, yeah, especially an old person lose their reflexes in 1 day too. But what else would you worry about? You've been in the bed for 3 days. Pulmonary embolus. Okay. Okay. Nausea, vomiting, melanoma. Yeah. Volume depletion. Syncope while in bed. It's unusual.
Residency.
I mean, you got to ask me if you have spells, you ever have them in the bed, because if they, I mean, that changes differential. So what?
Seizure.
Well, seizure, but we're talking about they really have syncope. So if they syncope in the bed, what do you think of?
Arrhythmias. Arrhythmias.
Okay, arrhythmias. And what other really unusual thing?
Carotid hypersensitivity too, which is
Could be if they roll over the pillow, like something like that. What else? Or myxoma. That's when they change funny positions. Myxoma was missed for months by everybody, including cardiologists. Okay, so where do we stop? Okay, this is your case. 24-year-old resident of Baptist South complained of sickness spell over the past year. These have occurred while being grilled on rounds by Dr. Leslie Harris. In a procedure by 2 to 4 seconds, lightheadedness, 2 of the falls associated with facial trauma, not associated with incontinence, and followed by fatigue, not confusion.
Situation.
Right, so neurocardiogenic. So what would you tell the resident? What would you tell them?
Switch it.